po is you have excessive range of motion, but the patient cannot control that motion within that range. Okay? So, nasundan po yun. So, ito yung makikita natin na common na nagkakaroon ng excessive ROM, then pag-move, diretso na yun sa instability, fracture, or any type of injuries po. Okay? So, clear tayo sa difference nitong tatlo. Mabilis makita yung hypomobility. Magkakaroon lang naman kayo ng confusion between hypermobility and laxity, but again, laxity is normal. Okay? So, that is for your ROM. Another is this one. What's causing the hypomobility? The ones causing the hypomobility can either be your myofascial, your pericapsule, or your pathomechanical. So, ano yung difference po na yan? Myofascial from the word itself, myo. Myo means muscle, right? Okay? So, pag sinabi natin yung myofascial, the ones that's causing the hypomobility is actually your muscle. So, may mali dun sa muscle natin. Okay? So, pag sinabi natin myofascial, there is shortening or hypertonicity of your muscles. Okay? Or from post-traumatic adhesions or your scarring. Okay? Pero basically, it's actually the muscle that is problematic. Okay? For your myofascial. Pag sinabi natin pericapsular, nandun na sa pangalan mismo, capsule. Okay? So, capsular or ligamentous in origin siya. Okay? So, the one that is actually problematic are your capsule or your ligaments. Okay? Pathomechanical from the word itself, mechanical. It has something to do with trauma. So, the ones causing this one is any traumatic injuries po. Okay? So, that is for your hypomobility. Nasundan po? Clear tayo with this one. So, these are just the causes of your hypomobility. Before we go to your resisted isometric, sabi nga natin, di ba, nakikita natin yung tinatawag na anatomical barrier of the patient kasi nga natutodo natin yung ROM, and since we can actually look at the end of the ROM, makikita natin yung tinatawag na end field pasyente natin. So in end field, this is very basic, but again, ang tendency is pag basic nakakalimutan natin, so daanan lang natin. So you have your normal and your abnormal end field. When we're talking about normal end field, these are your bone to bone, such as your elbow extension, so bone to bone. Kaya nagkakaroon ng end field because of bone to bone contact. You also have your soft tissue approximation, such as your ankle dorsiflexion and your shoulder lateral rotation. So these are just the common po, or the normal end field. For abnormal end field, you have your early muscle spasm. Early muscle spasm is the same, pero almost same as your muscle guarding. So if you have like protective spasm, so di ba kapag kunyari may masakit dito, ang nangyayari is para tayo nagkakaroon ng muscle guarding, so hindi natin sila minumove. Okay? So ang tendency is mukhang dulo na yon ng ROM mo, mukhang yun na yung just because of the muscle guarding. Okay? Very common also is your empty end field because of pain. So the patient's unwillingness to move because of pain. So that is your empty. So yung empty end field parang siyang pseudo end field. Walang nangyaring end field talaga, pero hanggang doon na lang dahil may pain yung pasyente natin. So common would be your springy blocks such as your meniscal tears. All of these are just your abnormal. But what you need to understand po, all types of normal end field can be considered normal end field in terms of the range of motion. For example, you are performing elbow extension, pero nagkaroon ng bone-to-bone contact. Pero pa lang po. Hindi pwedeng sabihin, ay elbow extension naman yan eh. And bone contact naman yan eh. So technically, on paper, it's actually normal. Hindi po tama yun. Kasi it occurs very early in the range of motion po. Okay? So any type or kahit tama yung end field, if it occurs early in the range of motion or late in the range of motion, it is considered to be, nasundan po yun? Nasundan? Clear po? May questions tayo? Clarification? Wala. Okay. If you don't have any question, let's go to your resisted isometric movements. Pag sinabi natin resisted isometric movements, usually it's tested last. Okay? So after your passive, so pag sinabi natin resisted isometric movement, isometric, meaning to say no net movement po dapat ang nangyayari dyan, and it is resisted. Why? Bakit very specific that it should be resisted isometric movement? Because what we can achieve here, or what we want to achieve here, is to actually isolate your contractile. Remember yung discussion natin kanina, you start with active na both inert and contractile yung stress. Then you have your passive na inert lang. Now the last thing that you want to isolate would be the contractile naman. So that's the reason why it should be resisted isometric movements. Bakit po dapat resisted isometric? It should be resisted isometric kasi papamove natin si patient pero no net movement po. Kasi bakit hindi pwedeng gumalaw? Dapat isometric, no net movement. Kasi dun sa resisted, magko-contract yung contractile structure, so that is good. Pero in order for the inert structures or the non-contractile structures na hindi ma-stress or hindi gumalaw, kailangan po isometric siya. Kasi kung hindi siya isometric and gumagalaw yung whole extremity, gagalaw din yung inert. So hindi natin ma-isolate yung contractile. So it should be isometric with no net movement para at least relax yung inert structures natin pero still nagko-contract kasi it's a resisted action. Does that make sense? Nasusundan po yun? Para siyang brake test na tinatawag natin MMT. Okay? So that is for your resisted isometric movement. So if there is pain during this specific action, you can actually say na, okay, we're dealing with we're dealing with what we call as your contractile structures. So that's how we perform the differential diagnosis grossly when we perform your movement analysis or examination of specific joints. Nasundan po yun? Nasundan? May questions po? Clarifications? Questions? Clarifications? Non-clear po tayo? Okay, sige. If you don't have any question, can we have like a 3 to 5 minute break po? I just need a CR break, honestly. Sorry po. Tumatanda na ako siya. So, CR break lang po. Mabilis lang kasi medyo mahaba-haba pa po yung discuss natin. Okay? Sige, 3 to 5 minute break lang po. Hello po, can you hear me? Hello? Okay, very good. Okay, so let's talk about the patterns of tissue lesion. Pag pinag-usapan, since we're done discussing na po yung tinatawag natin na examination of specific joints, so we were able to basically delineate whether we're talking about your contractile or your inert structures, right? So what we need to know is, hindi po kasi pwede na alam lang natin kung contractile or inert. We, again, without doing the imaging procedures, it is good for us to specifically somehow have a working diagnosis of what structures are we dealing with. So hindi po natin ma-diagnose lahat, but there are certain common patterns of tissue lesion na pwede natin pag-aralan. So let's start with this one. So starting with your inert structures. So kailan natin malalaman na we're dealing with inert? So again, when we perform active and passive, tapos nagkaroon tayo ng positive pain po. And increase yung pain kapag nasa-stretch yung structures or when they are actually pinched. So what are the common patterns of tissue lesions? Tatandaan lang po if we're dealing with inert, since we're dealing with the passive movement here, ang tinitingnan po natin would be number one, pain. Lagi pong may pain. Hindi mawawala ang pain because we're dealing with a lesion. As long as may lesion po, may pain yung pasyente dapat. So hindi mawawala yung pain po natin. Okay? So pain is always constant. And another thing na kailangan natin tingnan dito is of course the range of motion, because again, since we're dealing with passive movement here, there is range of motion here. Okay? Kasi nga passive movement, di ba sa passive movement, anatomical barrier, so makikita natin the full ROM of the patient. So ang titingnan natin would be the pain and the ROM of the patient for inert structure. So what do you mean kaya? So sabi dito, the first pattern would be pain-free and full ROM. So there is no pain and full range of motion. Ano kayang implication po nung first bullet? If there is no pain and there is full range of motion, this means that, yes, everything is actually normal. Okay? So if there is pain-free, full ROM po, this is actually normal. Bakit siya normal? Kasi walang mali. Wala kang nararamdamang pain, wala kang nararamdamang any limitation in terms of the range of motion. So that is normal po. Now let's go to the second one. If there is pain, okay, and limited ROM, the most important thing here, every direction. So there is ROM every direction po. Pain and limited ROM in every direction. So this is a very, very classic example of pattern of lesion for your capsule. Okay, so this is for your capsule. So there is pain and limited ROM again in every direction. That is for your capsule. So with this kind of pattern of lesion po, the next thing or the best course of action for you to do po is to actually check the capsular pattern. So you notice, okay, there is limitation of motion in every direction. So for you to solidify your diagnosis, you can actually perform or you can actually check your capsular pattern. If the patient is following capsular pattern, medyo sure na po tayo na, okay, this is a capsular injury. Okay, next would be you have pain and excessive ROM in some direction po. So hindi lahat ng direction, in some direction. This is a classic. Okay, this is a classic pattern for your ligaments. Okay, so this is for your ligaments po. Okay, again for your ligaments. Okay, and pain-free and limited ROM. Okay, so pain-free, limited ROM. This is for your osteophyte formation. So this is for your osteophyte formation. So what happens here without any type of comorbidity po, nagkakaroon, for example, nagkaroon ka ng early bone-to-bone contact with elbow extension, nagkaroon ka ng early bone-to-bone contact without any comorbidity, magkakaroon ka ng early bone-to-bone contact because of your osteophyte formation. But pain-free, limited ROM po. Nasundan yun? Again, pain-free, full range of motion, that is normal because basically you're not feeling anything for the patient. Pain and limited ROM in every direction, that is for your capsule. Pain and excessive or limited ROM in some direction, that is for your ligament. And pain-free, limited ROM, that is classic for your osteophyte formation. Okay? Are we clear with this one po? Clear tayo? Questions, clarifications? This is a very, very common po na question when it comes to international examination. Patterns of lesions. Okay? Let's now go to your contractile. So kung kanina we talked about your inert, let's talk about your contractile. For your contractile, ang contractile po natin would be, again, these are your contractile structures. So this is for your resisted. So we nagkakaroon tayo ng pain when we perform both active and resisted motion. Okay? So muscle contraction ang tinitignan. Since we're talking about your muscle contraction, so kung kanina ang tinitignan natin would be pain and ROM. Again, this one is pain and the strength of the muscle contraction. Lagi pong may pain because we are dealing with a lesion. Hindi pwedeng mawala yung pain kasi may lesion tayong tinitingnan. So we deal with pain, okay, and the strength of the contraction po. Okay, so pain and the strength of the contraction. So number one, let's look at this one. There is no pain and the movement daw po is strong. Ano po yan? Ano kayang pakinabang? Ano kayang goal niyan or ano yung makikita natin for the patient? So there is no pain and movement is strong. What's the implication of this one? This means that yes, basically, this is normal, right? So no pain and movement is strong. This is normal for the patient. Second would be pain and movement is relatively strong, but not as strong as it should be. Okay, so malakas ka, pero hindi na gaya ng dati. Charot, parang break up dito ah. So malakas ka, pero hindi na gaya as you were before, if that makes sense. So the patient can still do an activity, but not as normal as it should be. Okay, so this is very common po for isolated lesion. Okay, so this is for your isolated lesion po. So classic example of your isolated lesion are like partial muscle tear, you have your you have your tendinitis, tendinosis, paratendonitis. So basically isolated po. It's not like the whole tendon, but there is something wrong with the tendon. Isolated part of the tendon po. Okay, or complete no, not complete, partial muscle tear. So there is muscle tear that is happening, pero partial lang po siya. Okay, so meaning to say hindi completely sira yung structure. That's the reason why the patient can still perform the activity. So movement is relatively strong, but again hindi siya ganun kasing lakas as before. Okay, so this one pain, actually it should be extreme pain and the movement is weak. This is for your severe lesion po. Classic example would be your fracture. Okay, so classic example would be your fracture. So this one, there is very severe type of pain and this is for your severe lesion. Okay, so again, classic example would be your fracture. And lastly, there is no pain and the movement is weak. So technically, you're not feeling any pain na po, pero the movement is very, very weak. This is very common for your complete muscle there. So technically, there is no connection na, kaya wala kang nararamdaman na po na pain, okay? But the movement is really, really weak, primarily because naputol basically yung muscle ng pasyente natin, okay? So again, this one, no pain and movement is strong, that is normal. Pain, but movement is relatively strong. This is for your isolated lesion, again, such as your bicep, bakit pa puro ko biceps? Tendinitis, tendinosis, paratendonitis, and partial muscle tear. Pain and movement is weak, that is for your severe lesion, so such as your fracture, and no pain and movement is weak, that is very common for your complete muscle tear, okay? Clear po tayo with this one? Clear? Questions po sa pattern. Again, yung patterns of tissue lesion, it's not going to answer all of the diagnosis. But again, these are the most common na makikita natin na, what do you call this, na physical, MSK conditions po. So meaning to say, without going through the imaging processes, medyo may idea na tayo what's really going on with the patient. Clear po tayo with this one? Clear? You have any questions before we enter your special test? Wala. Okay po tayo for the differential diagnosis, ha? Sige. If you don't have any question, let's do your special test. So again, your McGee is basically discussing your special test. What I'll be discussing po is just your cervical and your upper X, syempre. Okay? So I'm really not sure who's going to discuss the lower quadrant screening, but for the lower quadrant screening po, you'll be discussing the remaining spinal segments and of course your lower X po. Okay? So let's talk about your special test. So special test is, these are not your these are not your gold, hindi ito yung gold structures natin, no? So your gold ancillary procedures, no? So hindi ito yung gold standard, that's the word. Hindi ito yung gold standard natin when we're performing your differential diagnosis. This is not your gold standard. This is more like an adjunct to our diagnosis or an adjunct when we perform your differential diagnosis po. Okay? So ano ba yung pinaka-use ng special test natin? Ang pinaka-use ng special test is, it is used to confirm a specific or tentative diagnosis. It is used for your differential diagnosis. So it is used to differentiate between structures, basically when we perform differential diagnosis, and it's used to understand unusual signs and symptoms, and of course, it is used to unravel any difficult signs and symptoms also. So basically an adjunct po, no, to our differential diagnosis. So let's start with your cervical spine. Before we go to cervical spine pala, if there is laterality when we're performing your special test, saan po natin pine-perform una yung special test? Affected or sa unaffected side? Saan muna tayo nagpe-perform? We perform first on the unaffected or affected? We perform sa unaffected. Ang tanong bakit? Bakit tayo nag-unaffected? Ano yung gusto natin makuha? Why do we perform unaffected? Yes, for baseline and for comparison. Okay, again, gagawin lang natin yan if meron tayong laterality, ha? So for baseline or for comparison, we perform first on the unaffected side. So starting for your cervical spine, okay? So with this one, so again, sa special test po, di ba may mga name yung mga tinatawag natin na special test, okay? It's really not that important for us to memorize the name. Dito po kasi, if you're aiming for the local board exam, the name is very important, okay? Kasi yun yung tinatanong po nila. Pero pagdating sa international exam, hindi na tinatanong yung tinatawag na name. So name is not that important. What is more important? Tatlo yan eh. So ang tinatanong would be the indication, the procedure, and the positive sign. Ang positive sign po, hindi na din natin masyadong dapat very anal about it or very hindi tayo sobrang dapat gigil dun sa positive sign kasi hindi po masyadong tinatanong ang positive sign. Bakit hindi tinatanong ang positive sign? Kasi 80% ng positive sign sa special test, ano po ba? Hindi lahat ha, pero majority ano ang positive sign? Exactly, pain. Okay? So hindi siya mahirap. Okay? So hindi nila tatanungin yan. Kasi kadalasan po is pain naman yung positive sign. Okay? So ang kailangan nyo malaman is saan siya indicated. Okay? Para saan? Yung special test na yun. Anong specific diagnosis siya ginagamit and paano mo siya i-perform. These are the two things that they will ask 170 million% for any international examination. They will ask para saan yung special test and paano i-perform. So Dedma, if you're not familiar with the name, as long as you know the indication and the procedure, you're good to go. Okay? This will make sense more po, okay, when you discuss your non-negotiable principles for your MSK conditions. That is with Doc Ed. Okay? So pag nag-NNP na po ba kayo? Hindi pa, no? Hindi pa. Sure ako, parang hindi pa. Kasi katext ko si Sir B, tinanong ko yan eh. Hindi pa, no? So yeah, when you do NNP with Doc Ed, okay, this week daw po, yeah, no, kasi natanong ko natin kay Sir B para alam ko kung saan, I usually ask ko ano yung mga natapos niya para alam ko ano magiging baseline ko for discussion. Pero yes, this will make sense. So if you can attend the NNP with Doc Ed na live, please do so because it's a really, 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 really beautiful discussion and everything will actually make sense pag diniscuss niyo yung NNP. So ang nangyayari po dun is parang, from the word itself, and SRG is the only one na meron ganon. So NNP is non-negotiable principles, so basically the pillars of your MSK conditions. So if you can attend the live, please attend the live. So this will make more sense. So ang kailangan nyo tandaan po would be the indication and the procedure. So let's start with this one. So the name of the test is your craniocervical flexion test. So this is indicated for your deep cervical flexor muscle. So how do you perform this specific test? So patient in supine, knees bent, so para siya naka-hook lying, and head and neck and midline. So paano mo ma-perform yung midline? Ang gagawin, bakit ako nagpapakahirap? May picture naman ako. Ang gagawin po natin is lalagyan natin siya ng inflated sphygmomanometer sa likod. Okay? The inflated sphygmomanometer should be inflated around 22 millimeters of mercury. Okay? So i-inflate nyo na po yan. Hindi po ilalagay nyo tsaka nyo dun i-inflate. Hindi. Ilalagay nyo siya na naka-inflate na. Okay? So around 22 millimeters of mercury. Okay? And ang gagawin po natin, kasi ang check natin is the deep cervical flexor muscle here. So in order for us to check this one, your instruction kay patient is you ask the patient to perform. Nasaan na yun? So you ask the patient, okay, to perform, ayun, by nodding. Okay? So nodding siya ha. So nodding is like this, nodding. Okay? Not chin tuck. Magkaiba po yun. So nodding, kung hindi mo makita sa leeg ko, nodding is like this. Ang chin tuck is paloob. Okay? Kasi ang tinigan natin is the deep cervical flexor, di ba? Flexor. When you chin tuck palikod, you're not flexing. When you nod, you are flexing po. Nagsusundan po. So you need to be very careful also with the action of the patient. So nodding is like this. Okay? So nodding po. Patient will flex the spine by nodding. So when you perform that one, malalaman po natin na okay yung strength ng flexor, deep cervical flexor ni patient if from 22, ma-achieve niya, kasi when you nod, there will be pressure here, right? So when the patient nods from 22, dapat umakyat to 26 po. Okay? So from 22, dapat umakyat to 26. Okay? Or if the patient cannot hold, okay, within 10 seconds po, yung contraction, so inanod niya ng 10 seconds, diba? Pag hindi niya kaya ng 10 seconds, nod niya lang ng 2 seconds, that is still positive sign na mayroong weakness yung deep cervical flexor muscle natin. Clear po tayo doon? So again, if hindi niya maakyat from 22 to 26, and if the patient cannot hold the contraction, unable to hold the contraction for at least 10 seconds po, okay? Meaning to say may weakness yung deep cervical flexor muscle natin. Clear po tayo doon? Clear? Okay, very good. Okay, sige, let's now go to this one. Okay, so yung next would be your neurological signs and symptoms. The way that I present pala yung tinatawag na special test, Elmo will be hindi ko, props ko po si Elmo, baka na-stress kayo bakit may Elmo. Si Elmo po yung hindi ko siya kayang i-demo sa sarili ko. So si Elmo yung magiging concern ko siya i-demo. So the way that I present this special test, kung mapapansin nyo sa tinatawag na module nyo, is naka-cluster po siya, whether we're talking about your muscle, your neurological signs and symptoms, ligaments, and other structures po. So ganun siya. So lahat ng tinatawag na special test for your muscle, for your neurological, for your ligaments, magkaka-cluster siya para hindi kayo nalilito. Kasi nga po, ang pinaka-important dito is yung indication. So at least matatandaan nyo yung magkakasunod. Ang indication nun ay for ligaments, magkakasunod ang indication nun ay for muscle. So ganun siya hanggang sa dulo po, ganun siya naka-arrange. So this one we're going to talk about your neurological signs and symptoms still under your cervical. So in neurological signs and symptoms po, dalawa ang tinatawag na special test natin. So it can be aggravating or relieving type of test. Okay? So it can be aggravating or relieving type of test. So pag sinabi po natin relieving type of test, relieving from the word itself, marirelieve yung pain ni patient. But you can only use your relieving type of test if pumunta si patient sa clinic nyo na meron siyang pain. Kasi ang positive sign ng relieving type of test is the decrease of the pain of the patient. So hindi mo yan pwedeng gawin if pumunta yung pasyente mo, wala naman siyang nararamdamang pain. Okay? So wala kang positive sign. So that's the reason why most of the time ang ginagamit is aggravating. Kasi hindi naman laging pupunta yung pasyente natin na may nararamdamang pain. Aggravating is you will elicit the pain to confirm the diagnosis. Okay? So again, relieving is a decrease of pain. This one, you're going to aggravate the pain to confirm the diagnosis po. Okay? So let's start with your relieving type of test. The classic example is your distraction test po. So the distraction test indication again, neurological symptoms, radicular symptoms. So how do you perform this one? You perform this one by placing yung kamay ni PT sa tinatawag na mandible, okay? And occiput ni patient. Bakit po mandible and occiput? Kapag orthopros na ba kayo simula nung last na nagkita tayo? Or hindi pa? Gone na po kayo with ortho. Okay, sino nag-orthopros sa inyo? Si Red. Okay, very good. So, napapansin niyo po sa cervical orthosis natin, okay? Laging ang plating is nasa mandible and occiput, right? Kung mapapansin niyo, 4-poster plate nandito siya. Okay? Wala kayong makikita masyado on the lateral, right? Laging ang plating, kunyari, even the minerva, even yung mga soft collar, the support will always be on the mandible and occiput. Why? Because in cervical, your mandible and occiput are usually what we call as your key points of control. Okay? So, pag sinabi natin key points of control po, from the word itself, these are the key points that when we move, mamumove natin the whole structure or the whole area or that aspect of the body po. So, in this case, since we want to lift the cervical, okay, your mandible and occiput will be the key points of control for your cervical. So, ang positioning po is laging dito and dito to fully lift the cervical. Bakit natin siya dinidistract? Because, again, this is for radicular symptoms. For example, you have your cervical radiculopathy. Ang nangyayari is kaya ka nagkakaroon ng radiculopathy, it's because of the compression and the decrease of space around here. So, the thinking is when you lift it up, magkakaroon tayo ng increase in space, therefore, nagkakaroon ng relief of pain for the patient. Okay? Nasundan po yun, yung distraction. Tinatanong yun na yung key points of control. For cervical, it's your occiput and mandible. Okay? Clear? Sige, if this is clear, let's now go to your aggravating test. For your aggravating test, we have what happened? We have what we call as your foraminal compression test. Okay? So how do you perform this one? This is may 3 parts po ang foraminal compression test. So the first part is, ang gagawin po natin dito is laging you press the head downward, towards the spine po. The first one is you press the head downwards with the patient in neutral head position. So in neutral head position, so tapos ang gagawin po natin is press down. Neutral head position, press down. Again, neutral head position, press down. If there is pain po on the upper X, nagkaroon ng radiation of pain on the upper X, you're positive na with your foraminal compression test. So there is radiculopathy or there are nerve root symptoms here. Okay? You can actually stop if nagkaroon na ng positive sign. But for example, in neutral head position, tapos nag-press down ka, wala siyang naramdamang pain, you can perform the step 2. Yung step 2 po natin, from neutral head position, you're going to extend. So neutral head position, you're going to extend. Pagka-extend po natin, press down again. Okay? So press down. Kapag nagkaroon ng radiation of pain on the upper X, you can also stop. Okay? Pero again, kung wala pa din, so ang gagawin natin part 3. So from here, extend. Okay? So again, from neutral, extend, then lateral flexion po. Okay? So neutral, extend, lateral flexion po. Then from lateral flexion, you press down. As you can see here, dito sa tinatawag na picture, wala lang lateral, wala lang tong extension. So lateral flexion po. So neutral, extension, lateral flexion, press down. Here, kapag may lateral flexion na po, kung saan naka-flex yung neck, doon dapat mag-radiate yung pain ng pasyente. Okay? If nagkaroon ng radiation of pain, again, you're positive with what we call as your foraminal compression test. You don't need to perform the whole sequence po. You're going to perform lang po kapag hindi siya nagpa-positive with part 1, part 2, then siya ka magpa-part 3. Does that make sense? Clear po tayo? Okay, next. We also have what we call as your Jackson compression test. Your Jackson compression test is a modification of your foraminal compression test. So what happens kung kanina, di ba? From neutral, extension, and lateral flexion, now in Jackson compression test, you stabilize the thorax of the patient, as you can see. Now from here, you rotate. So from here, you rotate po, okay, the head of the patient, and you press down. Okay, so you rotate, and you press down. Again, kung saan naka-rotate ang mukha, or saan naka-rotate ang head, dun dapat magkakaroon ng radiation of pain. Okay, so there's radiation of pain here. Again, you're positive with what we call as your Jackson compression test. Okay, clear po tayo dun? Clear? Okay. One of the most important special tests that you're going to encounter for your upper X is your upper limb tension test, or what we call as your ULTT. So we have different types of ULTT. Let's start. There you go. So you have four, ULTT 1, 2, 3, and 4. Actually, you really don't need to memorize this specific table po. The way that I study your ULTT po, ang ginagawa ko is tinitingnan ko kung ano yung similarities nila and yung difference nila. So for your ULTT, look at all the ULTT po, no? Lahat from ULTT 1 to your ULTT 2, all of them may depression and abduction. Ang nagkakaiba lang is yung tinatawag na levels or the degrees of abduction. But basically, lahat sila may depression and abduction. Look at your elbow. All of the elbows are in extension. Specifically, ang wala lang would be the flexion on your ULTT4. Now, look at ULTT1 and ULTT2. Look at the position. Sa lahat ha, your ULTT1, you have depression, abduction, extension, supination, extension. It's the same, exactly the same. Extension, supination, extension, supination, extension, extension, extension. Saan lang sila nagkaiba? In terms of the degree of the abduction. So if this is your ULTT1, okay, ito na lang si elbow. If this is your ULTT1, so you have your depression, abduction to 110 degrees, extension of the elbow, supination of the forearm, and extension of the wrist. This is your ULTT1. Your ULTT2 is basically this, pero binaba mo lang. Because the abduction, instead, it should be 10. Yes, there you go. Instead of 110, 10 degrees lang siya. So from your ULTT1, baba mo, that's ULTT2. Nasundan po yun. ULTT1, ULTT2. Now from your ULTT2, look at your ULTT3. Parehas po sila. Mali yan ha. Hindi yan 110. 10 degrees dapat yan. So from parehas sila. Depression, abduction to 10 degrees, extension of the elbow, pero nagkaiba lang with forearm and wrist. Instead of supination and extension, it's pronation and flexion. So basically, ULTT1, right? Binaba mo ULTT2, ikot mo. That's ULTT3. Okay? So from here, ikot. So instead of supination, pronation na nangyayari, and instead of extension, flexion na nangyayari. So this is ULTT1, 2, ikot is 3. Okay? So ULTT1, baba mo, ULTT2, ikot mo yung kamay mo, that is ULTT3. Nasundan po yun? Nasundan? Okay. Now your ULTT4 is the easiest to memorize because ito lang siya. ULTT4, nag-iisa siyang may elbow flexion. So ULTT4, nag-iisa siyang may elbow flexion. Your what do you call this, forearm, either supination or pronation, and yung tinatawag natin na wrist is actually in extension. So parang your waiter's deformity. Okay? So this is your ULTT4. Again, ULTT1, baba, ULTT2, ikot 3, and this is 4. Okay? Clear po yun. I don't really memorize the whole table itself. I tend to act it out. Pero pagdating po sa prometric, hindi kasi kayo pwedeng magkanon. Kasi pwede kayo mapalabas. Pero it's easier for you to, at early phase of memorization, it's easier for you to learn these things if you act it out. So again, 1, 2, ikot 3, then 4. Okay? So those are your ULTT. Ang importante lang naman would be the position. Now, another thing na important sa kanila would be your nerve bias. When we say nerve bias, these are the nerves na na-assess or nasa-stress natin during the performance of ULTT 1, 2, 3, and 4. So kapag may tingling sensation or kapag meron tayong tinatawag na pain or any type of symptoms, ito yung nasa-stress na nerves natin. Okay? So for your nerve bias for your ULTT 1, yung plan B po dyan is actually your MAC, MAC. So MAC, bakit siya MAC? Median nerve, anterior interosseous nerve, C5, C6, C7. So that is for your MAC. Again, median nerve, anterior interosseous nerve, C5, C6, C7. Now for your ULTT2, that is MAM, M-A-M. Okay? MAM, bakit siya MAM? That is median nerve, axillary nerve, and musculocutaneous nerve. Okay? Again, this is MAC, MAM. ULTT3 is radial, and ULTT4 is actually your ulnar. Again, MAC, MAM, radial, ulnar. So again, MAC, MAM, radial, ulnar. Okay? So MAC, MAM, radial, and ulnar. Okay? That is for your ULTT. Nasundan po yun? Nasundan? So this is your ULTT1. Okay? This is ULTT2, 3, and 4. Okay? Mali yung ano, yung pansinin yung caption na yan. Mali po yan. Okay? Clear po tayo? You have any questions? Clarifications? Questions po? Clarifications? Wala for your ULTT? Are we clear? Okay, if you don't have any question and clarification, let's look at your cervical spine. This kung kanina, neurologic signs and symptoms, now let's deal with your radicular symptoms po. This is a relieving type of test also. This is what we call as your shoulder abduction test. Other name of this one is your Bacodes. That's your Bacodes sign. Okay, so how do you perform your Bacodes sign? So patient in sitting or lying position, but it's actually more on sitting. So passively or actively ask the patient po, okay, to elevate the arm through abduction. So yung hand po natin, nakarest, yung forearm natin nakarest on top of the head, just like this one. Okay, if there is a relief of signs and symptoms here, you're positive with this specific exam. So this po kasi parang nasa stretch and increase natin yung space around here. That's the reason why nagkakaroon po tayo ng relief of symptoms. Okay, so that is for your Bacodes sign. Okay, Bacodes or your shoulder abduction test. Another test is what we call as your okay, magkamukha yung dalawang test na magkasunod. So that is for your Barry's test and your Hotans test. Okay, parehas po silang for vascular signs and symptoms. So let's talk about your Barry's test first. So Barry's test, patient in standing with shoulders forward like this. Okay, then flex to 90 degrees, elbow straight, forearm is supinated. Okay, so nakaganyan yung patient natin. You ask the patient to close his or her eyes and dapat ma-hold ni patient yung position na to for 10 to 20 seconds. Now, magpa-positive sign po if bumaba, okay, tapos nag-pronate. So if bumaba tapos nag-pronate, positive po si patient with Barry's test. Now, ano yung indication pag nag-positive si patient sa Barry's test? This means that there is diminished blood flow to the brainstem po. Okay, so there is diminished blood flow to your brainstem po. Okay? Kapag nag-positive siya. So again, the positive sign is pag bumaba, tas nag-pronate. Okay? Again, there is diminished blood flow to the brainstem. Another test na medyo kamukha niya is what we call as your Hotans. Your Hotans test is used to actually check what's causing the lightheadedness or vertigo of the patient, whether that is vascular impairment to the brain or non-vascular in nature. So again, if that's vascular impairment to the brain or non-vascular in nature po, okay? Ang tinitingnan natin po is yung tinatawag na nagkakos ng lightheadedness or vertigo, whether non-vascular or vascular in nature. So you have two parts here. So how do we perform? So in part 1, patient, okay, forward flex arm to 90, then eyes closed. Ang titingnan po natin is any loss of arm position. So kapag gumalaw siya. So medyo positive ako dito. So makikita niyo po, pag gumagalaw siya mag-isa, tapos pag inopen mo yung eyes, mawawala. Biglang magsi-stable. You're positive with part 1. Meaning to say, yung nagko-cause po usually ng migraine ko, lightheadedness or vertigo is non-vascular in nature. Okay? Now, if hindi ka nag-positive with part 1, you need to perform your part 2. So how do we perform this? You ask the patient to extend and rotate. It doesn't really matter kung saan mag-rotate na side. So extend and rotate. Then kapag gumalaw ulit yung kamay ng pasyente, this one, this is your part 1. Medyo mali yung picture kasi dapat naka-close yung mata ni patient. So pag part 1, this one, ito yung naka-extend and rotate for part 2. If gumalaw po either dyan sa kamay, positive po tayo. Pag nag-positive sa part 2, meaning to say the one causing the lightheadedness, vertigo, or migraine is actually vascular in nature po. Okay? Clear tayo with this one? Clear? Clear? Questions? Clarifications? Okay, if everything's clear, let's try to answer these questions.